Everyone, and thank you for joining today's webinar. I am Leslie Appiah, and I will be moderating today's session, which is being hosted by the Female Oncofertility Scientific Committee of the Oncofertility Consortium. Our speaker for today's webinar is Dr. Michel De Vos, who will be presenting on IVM, or in vitro maturation of oocytes for fertility preservation. Dr. De Vos is an associate professor in reproductive medicine and senior medical director at the Center for Reproductive Medicine in Brussels. He is subspecialized in reproductive medicine and surgery by the European Society for Human Reproduction and Embryology and the European Board and College of Obstetrics and Gynecology. His current research activities are focused on reproductive endocrinology, polycystic ovarian syndrome, in vitro maturation of oocytes, and fertility preservation. Additionally, Dr. De Vos is the coordinator spokesperson of the Freezing Ovarian Tissue and Oocytes Consortium, which encompasses oncofertility research projects at the University of Brussels and Université Catholique de Louvain. At the end of Dr. De Vos's presentation, he will present two cases for discussion. And so please feel free to ask questions at that time. You may place your questions into the chat or unmute at that time and ask your questions. This will be an hour session. Without further ado, Dr. De Vos.
Thank you, Leslie, for this very welcoming introduction. I will share my screen now. Okay, here we go. So, good afternoon, good morning, good evening, colleagues. For women diagnosed with cancer, several fertility preservation options have been developed, and one of these options is oocyte or embryo cryopreservation after IVM, in vitro maturation of oocytes, and it's probably the least applied strategy when compared to oocyte cryopreservation after conventional ovarian stimulation or ovarian tissue cryopreservation. But it's a great honor for me to provide some insight on what IVM of oocytes really is, how it can be applied to women seeking fertility preservation, in which circumstances it may be used, and how efficient it may be. So let's talk about the definition of oocyte in vitro maturation for those who are not very familiar with the concept. Well, oocyte in vitro maturation is defined as the maturation in vitro of immature cumulus oocyte complexes collected from antral follicles. And this is the original definition, as first described more than 90 years ago now by Pincus and Ensman, and also by Bob Edwards more than 50 years ago. And this is based on the observation that immature oocytes can reach metaphase 2 spontaneously in vitro when they are removed from their follicular environment. And although a short course of ovarian stimulation with gonadotropins is commonly used in IVM programs in infertile women with polycystic ovary syndrome, there is no strong evidence from clinical trials that it should be ovaries should be stimulated in the context of human IVM. And then upon removal of these immature cumulus oocyte complexes, these complexes are incubated in vitro media, and then the oocytes are denuded and can be fertilized in vitro. What should not be considered IVM is the culture of denuded oocytes that appear to be at GV or metaphase 1 stage after controlled ovarian stimulation. So this is not considered a clinical IVM procedure. It's often referred to as rescue IVM. It's not conventional, and this approach has been proposed in low responders to ovarian stimulation to generate additional embryos for transfer. But in rescue IVM, oocytes are cultured in a denuded state from the GV to the metaphase stage, metaphase 2 stage in vitro. And IVM, in the absence of cumulus cell support, results in poor oocyte quality. So I'm not going to go into detail on this technology because it's not considered IVM. Now let's go back to the basics and to the history. Pincus and Ensman observed that immature rabbit oocytes were capable of maturing in vitro and being fertilized in vitro more than 90 years ago. And Rock and Mencken made the same observation in human eggs for the first time in 1944. And Bob Edwards reported the first successful fertilization of human oocytes matured in vitro in 1965. And then Lucinda Wieck, she reported the first successful fertilization after IVM, after rescue IVM, in fact, first live birth, which is ever since then, as I said, not longer considered as an IVM procedure. Cha first reported the live birth from IVM in a donor program. So the oocytes were removed from the ovaries during laparoscopy. But the very first live birth after IVM from oocytes retrieved transvaginally in women with PCOS was reported by Alan Trouncen. And then there was a modification to the simple removal of immature oocytes in unstimulated ovaries, and that was the addition of a trigger, of an ovulation trigger before the egg retrieval, first reported by R.C. Chian in 2000. And then IVM progressed very, very slowly. We discovered in 2011 that it was more efficient in the clinic to cryopreserve embryos after IVM rather than performing a fresh embryo transfer. And in Western Australia, Melanie Walls published very high live birth rates of more than 40% when she added maternal serum to the IVM media and when they cultured the embryos up to the blastocyst stage. Biphasic IVM is a more recent development in an attempt to improve the oocyte culture and to mimic the physiological status of the oocyte during culture. And then very recently we had publications of live births in the context of fertility preservation and IVM. So the team of Michael Grinberg reported the first live birth after transvaginal oocyte retrieval and IVM in a breast cancer patient. And we reported the first live birth after vitrification warming of oocytes collected from ovarian tissue specimens. So that's, in a nutshell, the history of in vitro maturation. And the adoption of IVM in reproductive medicine has been very slow because of the absence of high quality data about the efficacy and the safety of IVM. Many professionals in our fields have refused to accept IVM as a valid ART. Nevertheless, a small number of centers of expertise continued to further refine their IVM programs and published their results. And therefore, the professional societies finally endorsed IVM as a treatment option. So first, IVM was mentioned in the polycystic ovary syndrome guideline in 2018 by Helena Tide et al. And also in the fertility preservation guidelines of ESHRE. And last but not least, ASRM, the technology of IVM, has been considered no longer experimental. Who are patients mostly suitable for IVM technology? Well, in the context of IVF programs in fertility clinics, mainly women with high antral follicle counts who undergo IVF are very suitable for IVM because of their high number of antral follicles that can be punctured. And this is to avoid the risks such as ovarian torsion, ovarian hyperstimulation syndrome, and the side effects of hyperresponse. Some patients prefer not to undergo ovarian stimulation with gonadotropins. And in some countries, there are financial incentives to prefer IVM over conventional ovarian stimulation. But it's mainly hyperresponders with a narrow dose response window when the ovaries are stimulated who are most suitable for IVM in the context of IVF clinics. Other indications include women with resistance to FSH stimulation, or LH, as a result of defects in the FSH receptor or LH receptor. And of course, last but not least, in the context of oncofertility. If we look at the algorithm that all of you know regarding fertility preservation and the decision-making algorithm for female patients with cancer, it all comes down to the available time frame. Obviously, if at least 2 weeks are available before the start of cancer treatment, conventional ovarian stimulation followed by oocyte cryopreservation can be offered. If this time frame is not an option, if less than 2 weeks are available, then the most common option to be proposed is ovarian tissue cryopreservation. But on top of that, transvaginal retrieval of immature cumulus oocyte complexes for IVM can be offered if there is no time for standard ovarian stimulation. And these technologies can be combined. So on one hand, you could remove part of an ovary, but you could also at the same time perform an egg retrieval from the contralateral ovary to increase the source of gametes. And you can also combine ovarian tissue cryopreservation with the retrieval of cumulus oocyte complexes for IVM from the ovarian tissue specimen. And this is what is referred to as ex vivo IVM or ovarian tissue oocyte IVM, auto IVM. The first report of this technology was in 2003. And ever since then, more reports have followed. Presenting here also some percentages of the difference of the distribution of these technologies in our center in Brussels, where I have to say that about 60% of cancer patients still have oocyte cryopreservation after conventional ovarian stimulation, and more or less 35% of patients have ovarian tissue cryopreservation. But in our context, we always search for immature cumulus oocyte complexes when we remove a large part of the ovary. This cannot be done when you only remove a very small piece of the ovarian cortex, because as I will tell you in a few minutes, you really need to also remove the medulla of the ovary in order to have immature cumulus oocyte complexes available for IVM. And the transvaginal retrieval of oocytes for IVM is only a procedure that we perform in only 5% of women, because we really need to have women, cancer patients who have a very reasonable antral follicle count. And according to the data from our colleagues in Paris, Sonigo et al. From the team of Michael Greenberg, at least 19 antral follicles would be required to have a reasonable number of mature oocytes after IVM in the context of fertility preservation. So if we look at the variables that exist to guide the decision-making process in women with cancer, then if we look at age, then yes, it should be really young women until the age of 36 who could be suitable for IVM of oocytes after transvaginal egg retrieval, not in prepubertal patients. And the patient, well, basically, if we do not have 2 weeks available for ovarian stimulation, then this is definitely a possible indication. Also in conditions where ovarian stimulation is not is contraindicated. The functional ovarian reserve, as I already told you, should be really good in women with low antral follicle counts. I would really discourage you, and I would not recommend transvaginal egg retrieval for IVM because the yield will be very low. So we have several questions to ask now in this context. Is there a minimal antral follicle count cutoff in women to whom we would propose this technology? How should we prepare the patient? How do we actually perform an IVM egg retrieval? Is there any specific lab requirement to offer IVM in your clinic for cancer patients? And do we know the clinical outcomes of this technique? Now, this is a small video fragment of a patient who had a IVM egg retrieval from the through the vaginal route, where you see that this is obviously not a normal ovary. It's a polycystic ovary with a high number of antral follicles. So these patients are definitely the most suitable patients, where you can puncture several antral follicles, and you see that these follicles are small, they are very abundant, and the egg retrieval is very similar to the egg retrieval in stimulated ovaries. So we use the same needle, we use a slightly lower pump pressure, and the technique of how you approach the ovary with the needle is slightly different. So you twist the needle a little bit more. It's not a passive puncture, it's really an active puncture. As the operator, you're really actively puncturing the ovary. This is the largest series that has been published about vaginal egg retrieval for IVM in Paris. So the team of Grinberg has looked at IVM results in 248 breast cancer patients. Why breast cancer patients? Well, in France, letrozole co-treatment is illegal. It's not possible to administer letrozole out of the context of oncological post chemotherapy adjuvant hormonal therapy. So in the context of fertility preservation, letrozole is illegal, also in the context of ovulation induction, and therefore in women who have breast cancer, who would normally undergo ovarian stimulation in most other countries, this is not possible in many patients with breast cancer in France. So there it was found that either in the follicular phase or in the luteal phase, a very similar number of immature oocytes could be retrieved, and the number of oocytes after IVM was also very similar in both phases of the menstrual cycle. But if you look at these patients from this large series, they had a very high antral follicle count on average, also very high anti-Mullerian hormone levels. And if you also look at the oocyte recovery rate of about 40 to 50%, which means that if you puncture 10 antral follicles, you would expect around 5 oocytes to be retrieved during the egg retrieval procedure. The first live birth after fertility preservation and IVM was in a breast cancer patient, and this was a report by Michael Grinberg. And here he also emphasizes that this patient, it was impossible to consider ovarian stimulation, and because the oncology the oncologist would not allow the patient to be stimulated with gonadotropins, and letrozole was not an option either. If we think of ovarian tissue cryopreservation and the appended technique of IVM of oocytes retrieved from that tissue, then again, we are talking about young women. We would not recommend it in women above the age of 36 because of the lower potential of the oocytes, obviously. In women who do not have the time for ovarian stimulation, and in women who have a severe impact from chemotherapy or a predicted severe impact from chemotherapy, you would not remove a large part of the ovary if the predicted impact from cancer is rather low. So it's an appended technique in addition to ovarian tissue cryopreservation. The question is whether you have to refurbish your lab to accommodate for this technique. Well, apparently not. This is a very straightforward laboratory procedure. The logistics are also quite easy. And the question in this setting of ex vivo IVM is whether the clinical outcomes of this technique can be predicted. What do we know about the clinical outcomes of this technique at the moment? I will tell you. Now, at the moment, ex vivo IVM or ovarian tissue oocyte IVM is still considered experimental. And the thing is that there are limited safety data of this technology. There is no long-term follow-up of children born, of the few children born after this technology in cancer patients. The lower developmental potential of ex vivo IVM can be attributed to the non-selected antral follicles, including very small antral follicles that are ruptured during the processing of the ovarian tissue. Also, the suboptimal IVM protocol, especially in very small antral follicles that do not have, for instance, a functional EGF pathway, and that also require many more steps before they can reach full developmental potential. If we think in terms of transportation, if you remove an ovary and you have to transport the ovary for cryopreservation at another site, then the ex vivo IVM procedure is probably also compromised in view of the low transportation temperature conditions of the tissue. So it's actually a technology that has potential in women who undergo ovarian tissue cryopreservation, not in women who had recent chemotherapy, because obviously then the oocyte quality is compromised, not in very young children. It's probably mostly valuable in women in whom ovarian tissue transplantation afterwards is contraindicated. So in women with ovarian and hematological malignancies where there is risk of transmission of malignant cells to the patient. But here the optimization of the IVM culture system is very important in order to improve the efficiency of technology. So if you perform ovarectomy as opposed to ovarian cortex biopsies, then this is what you get in your culture dish, which is an ovary that you can then process in the lab. So you can open the ovary in order to separate the medulla from the cortex. It's the cortex that you want to cryopreserve because the cortex contains the primordial follicles, and in the medulla you will have very small antral follicles that during the cutting and the processing of the tissue will be inadvertently ruptured. And after this process, you will find in the culture, in the tissue, in the culture dish, you will find small debris that you can then process through a 70 micron filter. And after doing so, you will find under the microscope that in the dish, you will have several small cumulus oocyte complexes. These complexes can be incubated in registered IVM media, in air at 20% oxygen at 37 degrees for between 30 and 40 hours. And then after that, some of these oocytes will be mature, can be vitrified, or can be fertilized in vitro and vitrified for cancer patients. So this is the concept. And what did we find in our report of the series of patients in whom we offered this procedure of ex vivo IVM? So 77 women who had oophorectomy and IVM of oocytes ex vivo. On top of that, most women had oocyte vitrification, some women had embryo vitrification, young women mostly, average age 24 years old. The mean number of mature oocytes after ex vivo IVM was between 6 and 7. And well, the majority of our patients were breast cancer patients, and many women also had hematological tumors. Well, if we look at the maturation rates of ex vivo IVM, in this series, we had a mean maturation rate of 42%, which is slightly lower than the mean maturation rates that we can see if we perform a transvaginal egg retrieval for IVM. Obviously, if you perform a transvaginal egg retrieval, the follicle sizes will be slightly larger, and this may be an explanation for this. And in prepubertal patients, the mean maturation rate is really low, only 22% in our series, and this underscores the reduced ability to complete meiosis in vitro, especially in very young patients. We have published some live births. So in the 77 patients from this series, several patients returned to our clinic because they had a desire for pregnancy. And in 5 patients who returned, 2 of them immediately requested the warming of the ex vivo IVM oocytes, and this resulted in 1 live birth. And also some patients who had embryos cryopreserved after ex vivo IVM. In these patients, we also had live births. So the question here is whether we should propose this technology for young children, for prepubertal children. Well, the answer is probably the utility in these very young girls is doubtful. A publication in patients in Israel has shown that maturation rates in very young children is very low. And this also probably means that if we transplant ovarian tissue from these very young children later on, that the clinical outcomes of ovarian tissue transplantation will also probably be less good as compared to transplantation of tissue in slightly older children. If we compare survival rates of ex vivo oocytes that have been vitrified, then the survival rates are quite comparable to those after IVM egg retrieval through the vaginal egg retrieval. So that's more or less the same survival rate compared to the standard ovarian stimulation and vitrification of oocytes. There is still a gap, an efficiency gap, where the standard ovarian stimulation and vitrification of oocytes results in survival rates of between 80 and 90%. This is a slide that I'm going to skip for time constraints. Now, the question is why IVM is still less efficient compared to in vivo oocyte maturation. But you have to remember that if you release a cumulus oocyte complex from its follicular environment, then what's going to happen? Well, the cyclic GMP levels in that COC will drop, and this will result in activation of the phosphodiesterase enzyme, resulting in degradation of cyclic AMP and the resumption of meiosis. So there is hastened nuclear maturation, but the cytoplasm will not be able to keep up with the nuclear meiotic progress. The cytoplasm needs much more time to prepare for proper acquisition of developmental potential and to be able to have a fully competent oocyte that can be fertilized. There is much more time needed for the cytoplasm. And this means that only a fraction of oocytes that have been processed through IVM media will become fully competent after IVM. And one of the mechanisms of this this problem of egg quality after IVM is the retraction of TZPs, transzonal projections between the cumulus cells and the oocytes upon release of the COC from the follicular environment. There are important improvements of the IVM system underway, and this is mostly focused on the extension of the culture. So the introduction of a step of pre-maturation before proper IVM is probably a very valuable step, and this is being investigated in several centers these days. And this refers to a biphasic IVM system, where one of the components of this pre-maturation step is natriuretic peptide C, which gives more time to the cytoplasm to acquire developmental potential, because the meiosis will be inhibited for a bit longer. Mostly 24 hours extra will be gained with this procedure. If we look at safety scores, and we're almost at the end of this presentation, safety scores are very reassuring. Several studies have been looking at imprinting establishment, maintenance of imprinting marks, aneuploidy, there is no difference. Early pregnancy loss, same there, no difference compared to standard ovarian stimulation. Children after IVM do not have different birth weights and do not have a difference in congenital abnormalities. However, this table only refers to IVM of oocytes retrieved transvaginally. There is no such data set or safety score for ex vivo IVM procedures and offspring. Combining fertility preservation procedures is probably going to increase the options for cancer patients in the future. So instead of just freezing ovarian tissue or just vitrifying oocytes, there is a potential to combine procedures. So in our clinic, we have combined transvaginal egg retrieval for IVM with ovarian tissue cryopreservation and ex vivo IVM. So all these components can contribute to a larger set of gametes for patients to be used at later stages when they come back and when they find themselves infertile. Now, as a conclusion, we can say that IVM should be routinely integrated into the repertoire of technologies needed to maximize fertility preservation prospects for cancer patients. However, research is needed on how to integrate the options of conventional ovarian stimulation with ovarian pickup and IVM, ex vivo IVM, and ovarian tissue cryopreservation into clinical practice. So the decision-making algorithm still needs to be refined. there is no denial that improvement of IVM efficiency is really needed, not just for cancer patients, but for infertile women as well, who use IVM to get pregnant. And this requires innovative and sophisticated new IVM culture systems aimed at mimicking the in vivo oocyte maturation process. So I would like to have a break here and give you the option of asking some questions before we proceed with 2 more cases. Leslie. Oh.
Thank you, Michel. I just placed in the chat that the audience may type your questions into the chat or unmute and ask your question. And if not, in the interest of time, we are going to move to the first case, or perhaps if anyone's having trouble unmuting, just send a message. Okay, Michel, let's go on to the case.
Okay, thank you, Leslie. So this first case is a recent case, a 28-year-old woman who was referred to us by the hematologist. So she's nulliparous, she's married, she has been on contraceptive pills for a long time, and she was diagnosed with acute lymphoblastic leukemia. And the hematologist urged us that the patient needed chemotherapy very, very soon. We had the luxury, well, we have the luxury in our clinic to be able to immediately perform an ultrasound scan on our patients and also perform a blood test for AMH testing. So when we perform a blood test for AMH testing, 2 hours later, we have the results of the AMH, which is very comfortable in the setting of fertility preservation. So this patient has a normal AMH level of 2.3 or 16.5 picomole per liter, normal antral follicle count, 21 antral follicles, and suppressed pituitary gonadotropins as a result of the long-term pill use. So this patient is very sick. She needs to be treated as soon as possible with chemotherapy, and she has leukemia. So as per consensus, and this after discussion with the hematologist, it was proposed to the patient to perform ovarian tissue cryopreservation, but not immediately because of the high risk of cryopreserving leukemic cells together with the ovarian tissue. So it was decided that we would perform ovarian tissue cryopreservation after 1 or 2 rounds of induction chemotherapy. But the patient was really anxious. She wanted something to be done as soon as possible to preserve her chances of remaining fertile. So we saw her just before Christmas. That was when the blood test was done, when the intake of the patient was done. And we planned her to have a IVM egg retrieval a few days later, just after the Christmas weekend. And as you can see, we did not stimulate the ovary at all. And this is what we standardly do in the setting of IVM for fertility preservation. No gonadotropin stimulation, just an egg retrieval. At the same time, and this is very convenient, the patient is, so she's put to sleep by the anesthetist. We perform the egg retrieval, and just after that, the surgeon comes in and he inserts a porta-cat under general anesthetic. So it's a combination of strategies to prepare the cancer treatment for this patient. So the IVM was started in the morning of the 29th of December, and on the following day, we had 10 mature oocytes vitrified for this patient. So this is, I think, a very interesting indication for IVM egg retrieval, a patient who does not have the time to undergo ovarian stimulation and in whom ovarian tissue cryopreservation could be an option, but in leukemic patients, well, this is also quite controversial. Shall I?
Yeah, if you could pause there. So a question by Dr. Gilchrist. What is a portacath?
It's a device that is inserted underneath the skin and that offers a gateway to the blood circulation. So it's actually a device where you can stick a needle to administer chemotherapy so as to prevent repeated venopuncture in a cancer patient. It's a standard procedure for cancer patients who receive chemotherapy.
Michelle, I have two questions. One, are there any considerations that need to be taken when doing a transvaginal retrieval in someone with a hematologic condition, either infectious-wise or bleeding?
Yes, of course. Well, obviously, we need to have a platelet count. If the patient presents with a very low platelet count, we always have to have additional platelet bags at hand to administer before the egg retrieval. So you're right. If we have a platelet count below 50,000, then we obviously have to pump up the platelet level before we can perform the egg retrieval. But it's a very relevant question. We should not compromise the health of the patient in any strategy and intervention we perform in cancer patients. We really have to be really careful not to compromise the start of the treatment. And that's very relevant for egg retrievals, but also for ovarian stimulation, where it is extremely important not to have ovarian hyperstimulation syndrome in cancer patients, because that would compromise the start of ovarian of chemotherapy.
Thank you. Dr. Takai is asking, so no HCG priming was needed before the oocyte pickup?
Well, HCG priming has been a controversial topic for many years. Obviously, if you administer HCG to an ovary when there is no large dominant follicle available or present in the ovary, then there is no expression of the LH receptor. So the HCG would, in theory, not be able to introduce or initiate maturation of the oocyte. So there is no rationale to administer HCG. We know that HCG has been administered in the context of IVM more than 20 years ago by Chian, and the idea was to have at least one or two oocytes that are mature when you perform the egg retrieval. So this is a combination of in vivo maturation, so small antral follicles that can respond to HCG and give you a mature oocyte when you perform the egg retrieval. So this means that you already have some mature eggs after a so-called IVM procedure, but the other eggs that still need to undergo IVM do have a lower developmental potential. So there is no real need to administer HCG, not in the context of IVM for PCOS and not in the context of fertility preservation. Michael Grinberg has performed a comparative study where he looked at oocyte yields and oocyte maturation rates in women who had HCG priming, GnRH agonist priming, or no priming at all, and the results were exactly the same.
Excellent, thank you. Dr. Anderson is expressing interest that you had good M2 rates when the patient was so hypogonadotropic.
Well, obviously, we administer FSH and HCG in the culture media. So these COCs are actually thriving on HCG and FSH in vitro, but not before the egg retrieval. So it is apparently sufficient to treat the COC, the cumulative oocyte complex, for, let's say, 30 hours to introduce a proper physiological signaling pathway towards maturation. So you don't need to have it exogenous.
Excellent. All right, let's go to your second case.
Right, so this is actually a patient which was part of our publication by Segers et al. In Human Reproduction. So this is a 23-year-old woman with Hodgkin lymphoma, who has a rather severe type of Hodgkin lymphoma, which would not be treated with ABVD, but with the more aggressive BCOP regimen, which is also more conducive to ovarian damage. She had a normal anti-Mullerian hormone level when she presented and a normal antral follicle count. She was a contraceptive pill user. And just after the weekend, again, we offered her a combined strategy of transvaginal egg retrieval for IVM from one ovary, and the other ovary was removed by laparoscopy. And this resulted in 10 cumulus oocyte complexes from the vaginal egg retrieval. And from this ovary, unfortunately, only one oocyte was mature after IVM, so only 1 out of 10, which is very low maturation rate. And from the other ovary, we were able to identify 22 cumulus oocyte complexes during the ovarian tissue processing. And from these 22 oocytes, sorry about that, what's that? Eight oocytes became mature after IVM. So in total, seven there and one, so 8 mature oocytes for fertility preservation after IVM in this patients, with ovarian cortex fragments on top of that, of course. And then she was cured from cancer, and she came back to see us 2 years later when she was in remission, and she had a desire for pregnancy. Her AMH was then undetectably low, and she had pituitary gonadotropin levels that were compatible with menopause. So these 8 mature oocytes after IVM were warmed, and 7 out of 8 survived. So that's a very, it's a reassuringly good survival rate in this particular patient. So these 7 oocytes were fertilized in vitro using ICSI, and 3 embryos ensued, and 2 embryos of good quality were generated, and 1 10-cell embryo at the cleavage stage was transferred, and this resulted in a live birth. So this is an indication that ovarian tissue oocyte IVM, although it's a relatively experimental procedure, it does result in live births. Thank you.
Thank you. I have a question, Michel. So why the oocyte pickup from just one ovary? Was there a concern that if you tried to do that from both ovaries and then did an oophorectomy on one, that there would be some compromise?
Good question. I think if you puncture an ovary, the ovary will be quite damaged and bruised. So if you then remove it through laparoscopy and you give it to your embryologist, the embryologist will let you know that the tissue doesn't look really nice and really really healthy. So all the punctures, because obviously when you perform an egg retrieval for IVM, it's not just one puncture to aspirate all the oocytes from all the follicles. You really have to penetrate the ovarian cortex many times, and this results in bruising, bleeding inside the ovary, outside the ovary. So the ovarian cortex will be less healthy and less intact to cryopreserve.
Excellent. Patrizio, I am going to unmute you for your No, can't do that. So I'm going to ask his questions. Pasquale's question is, in both cases, you could have done 6 to 7 days of stimulation and proceed to harvesting. Why not? And thank you for a great talk.
6 to 7 days. Yes, but the thing is, if you talk about 6 to 7 days of ovarian stimulation, this means that you reckon that after 6 to 7 days, you will have follicles of a substantial diameter that will give you mature oocytes after ovulation trigger. So that's an abrogated ovarian stimulation, where a standard ovarian stimulation would be more like 11 or 12 days. So there you're taking a risk of having a suboptimal stimulation that you have to stop in time. And if you perform, well, obviously it's an interesting proposal, but I think that the maturation rates of oocytes after ovulation trigger in that case will be rather low. So you will definitely have some oocytes. But the thing is, do you really have 6 to 7 days in both cases? If you don't have this time available, then obviously it's not an option. But I agree that this is something to consider, and I'm not sure whether this has ever been published, to perform a very short stimulation in order to retrieve mature oocytes after conventional stimulation. Good comment.
Okay, well, we are 6 minutes from the hour. If you have any questions, feel free to unmute yourself. Otherwise, thank you so much, Dr. De Vos, for your very informative and enlightening talk. If anyone has any future questions, you may email Dr. De Vos. Do you want to put your email in the chat just quickly?
Yeah.
And this webinar will be recorded and placed onto the Oncofertility Consortium website, so you may access it after this session. And his email is now in the chat. Thank you, everyone, for participating. We really appreciate your participation and attention. Have a great evening, morning, afternoon, wherever you are.